Muy buenas tardes. Bienvenidos a esta sesión coorganizada por el doctor ALEXIS BEDOLLA y la doctora Edith ANTAL, cuyo título es Health, Philanthropy, and Capitalism, Scrutinizing the Role of the U.S. in the Development of Mexican Public Health. Voy a dar unas pequeñas palabras de introducción y luego le voy a ceder la palabra a Alexis, quien moderará la mesa. This panel will address an important topic at the heart of current understandings and practices of global health, that is philanthrocapitalism. In particular, the experts participating in the upcoming panel are renowned scholars that have extensive research experience regarding either U.S. philanthropic institutions or the role of pharmaceutical corporations in Mexican public health. Why is this relevant? As it has become evident through the present COVID-19 pandemic, one of the decisive elements that altered the evolution of the pandemic was the quick development and approval of vaccines. For their development, both private philanthropic institutions and pharmaceutical corporations played a crucial role. This is to say that, for instance, without the financial support of the Bill and Melinda Gates Foundation, and the technical expertise and industrial capacity of some pharmaceutical corporations, the story of this pandemic would have been entirely different, as vaccines would have taken much more time to develop. It is important to add that these corporations earned almost 25,000 million euros in the first semester of this year because of the high demand of their product. Considering thus the crucial role of philanthrocapitalism has played in the worst epidemic event that the world has faced in a century, it becomes relevant to analyze and problematize its role, noting the profound limitations of some of the underlying assumptions of philanthrocapitalism interventions in global health. Most notably, it is crucial to reflect on the underlying epistemological assumptions, the politics and the geopolitics involved in US philanthrocapitalist practices when we address their impact in low and middle income countries. It is therefore necessary to reflect critically on how the technological solutions created in the global north in the name of global health affect and are deployed in the global south. What implications do they have? What is their impact in countries like Mexico? Why is this issue relevant for CISAN? This is no doubt a particularly interesting and relevant topic that pertains CISAN's mission and objectives. Critically, it involves a discussion of US-Mexican relationships in regards to global health initiatives in the crucial historical juncture of the COVID-19 pandemic. It is an event that complements and expands the field of topics that are usually addressed in the conferences hosted at CISAN, that has furthermore the potential of reaching new scholarly audiences and create new institutional networks. I want to thank Dr. Edith ANTAL and Dr. ALEXIS BEDOLLA for coordinating this event and our expert panelists for being here in this Mexican autumn afternoon. The floor is yours, Alexis.
Thank you very much, Graciela. Thank you very much for this brilliant introduction and for facilitating, well, helping us facilitating the resources to host this fantastic panel at CISAN. So hi everyone again, my name is Alexis Bedolla. I'm a postdoctoral researcher here at CISAN. And as Graciela mentioned, me and together with Dr. Edith ANTAL, we're the academic coordinators for this event. And today I will be acting as moderator. So we are truly delighted and honored to have this fabulous panel today. This is, of course, a stellar panel that I've been dreaming of about. We have top experts in their field talking about either philanthropic institutions or either big pharma, right? So let me briefly introduce and provide a little bit of context for today's event. So when talking about Mexico's public health, we are used to think in all the things that our politicians and public officials do wrong. Decades of neglect and abandonment, lack of proper finance and investment in health workers and infrastructure, poor political and policy choices, and so on. And indeed, of course, this explains a lot of why our public health system is in the condition that it is now. However, the purpose of today's event is to explore some of the outside forces and influences that also critically intervene in some respects to determine both policy decisions and health outcomes. In particular, we believe that in Mexican academia, we need to critically discuss how philanthropic institutions and pharmaceutical corporations have also played an important role in the constitution and development of Mexican public health. So as is widely acknowledged, philanthropy and big pharma most often than not lack democratic controls, favor the use of what can be called market ways of looking at things, bypassing governments. And philanthropy in particular usually reflects a view that the winners of an unjust status quo, like Bill Gates, are some sort of saviors that have the appropriate tools, knowledge, and values, some sort of, they have the secret to address injustices and social issues by doing well by doing good. Nonetheless, there's no doubt there's a profound tension in the practices of liberal philanthropy and capitalist initiatives of pharmaceutical corporations and the actual outcomes of their interventions. The building of billionaire fortunes that enable them may have caused serious societal problems in the first place, especially in the places where their action is directed, as Graciela mentioned, is usually the global south. So the panel of this afternoon is an invitation to our audience to think about this tension. So before we start, I would like to mention some housekeeping rules. The panel is scheduled for 2 hours. We will have back-to-back presentations following a Q&A session. Each presentation is scheduled to be about 20 minutes, and the rest of the time will be for questions and discussion. Since we are in a special platform today, I would ask our audience to please type your questions either on the chat box of CISAN YouTube channel, or if you are following from CISAN's Facebook page, you can post your questions there. It's important to mention that any questions you may have for our panelists today can be asked in English or in Spanish. And although I'll read the questions after the presentations end, they can be posted in the chat boxes at any time during the event. So I thoroughly encourage our audience to participate and engage with our brilliant presenters. Without further ado, let me introduce our first presenter for this afternoon. Anne-Emmanuelle BIRN is Professor of Global Development Studies and Public Health at the University of Toronto. Her research explores the history, politics, and political economy of international and global health, focusing on Latin American health and social justice movements, among other topics. She has published a numerous of fantastic books, such as The Marriage of Convenience, Rockefeller International Health and Revolutionary Mexico, Comrades in Health, US Health Internationalists Abroad and at Home, a fantastic textbook of global health. And most recently, he published with Duke University Press, Peripheral Nerve, Health and Medicine in Cold War Latin America. Her current projects examine the history of child health, child rights in Uruguay, social justice-oriented South-South health cooperation, the health harms of Canadian extractivism, and the history of global international health in the Americas. Professor BIRN is a former Canada Research Chair in International Health and was recognized among the top 100 women leaders in global health. She was a member of the Independent Panel of Global Health Governance, Global Governance for Health, and it's now part of the Political Determinants of Health Collective, based on the University of Oslo. So we are in a treat today. Professor BIRN, today's presentation is titled Rockefeller International Health and Revolutionary Mexico, Anatomy of Our Relationship. So the floor is yours, Professor BIRN. Thank you very much.
Thank you so much. It is a real treat to be with you. I'm deeply honored. Y hablando del imperialismo americano, me sabe mal hablar en inglés, but that's the way things go. So I start here with some images from Time magazine, and this functions on multiple levels. First, Time, of course, is a mouthpiece of American capitalism, and so gauging its covers are a kind of an entree into an understanding of the times. Secondly, you see that Time's coverage changes over time, and we'll come back to this in a few minutes. You see a portrayal of Lázaro Cárdenas, president of Mexico in 1934, looking vastly different in 1938. And third is that the book that Alexis so kindly mentioned was actually produced a long time ago. So I am revisiting some work from actually several decades ago, and let's see how we go with that. So what I would like to do is spend my time, my 20 minutes, exploring 5 inflection points, one around capitalism, Rockefeller philanthropy, and disease campaigns, then looking at revolutionary Mexico and the first Rockefeller program, the Yellow Fever campaign that was really a problem for the US, not Mexico. Then looking at the institutionalization of public health through both hookworm campaign and health units, and looking at the ways in which this on one level undergirded capitalist expansion, on another, the building of a modern Mexican state in revolutionary times. Then we'll look at resisting capitalist approaches to public health in the Cárdenas years, and finally take a look at art, science, politics, philanthropy, and legacies for the president, hopefully be leapfrogging into the next presentations. So to begin, John D. Rockefeller was, and by some counts, is the wealthiest American ever. At one point, he controlled 90% of oil production in the United States and beyond. He was the first billionaire and controlled between 2 and 3% of the US GDP at its peak. And he was part of a movement which Andrew Carnegie, another robber baron, labeled the gospel of wealth, that very wealthy Americans, capitalists, industrialists, needed to give back to society, not just through religious charity, but systematically. In the case of Carnegie, via libraries, bathhouses, investigation in peace, investment in education and science. And Rockefeller took this to another level through so-called scientific philanthropy starting in the 1890s. And here the idea was to invest in scientific education as well as other levels of education and scientific medicine and public health, which were considered neutral arenas that might stave off some of the critiques of the Rockefeller philanthropy, monopoly in oil, as well as some of the very untoward behavior, repressive behavior against workers in various Rockefeller-owned establishments, such as Colorado Mines and so on. So the foundation was established in 1913 with this very ambitious motto to promote the well-being of mankind throughout the world. And you can think about John D. Rockefeller's own motive as both stemming criticism and his personal salvation. He was a deeply religious Baptist man. In fact, he had a Baptist preacher advise him. His name happened to have been Gates, no relation. Frederick Gates was his religious, his spiritual, and his philanthropic advisor. I just want to pause a century ago, 120 years ago, to think about philanthropy. Yeah, the Oxford English Dictionary's definition is very mild and felicitous, the desire to promote the welfare of others, especially through generous donation of money to good causes, right? But the public was far more savvy a century ago and understood that philanthropy fit into whether it was extractive capitalism, capitalist expansion, or welfare capitalism. And we may circle back to this in the discussion. So you see this workers' journal, The Comrade, that depicts a fat cat capitalist who is stealing money from the pockets of the worker who is literally greasing the wheels of capitalism and then giving a little bit of a donation to a hospital. So this is how the worker is robbed, and so-called Christian philanthropy as it's seen. And just in case you don't quite get it, the statue with the clarion call is Cynicus. So there we go. So the Rockefeller Foundation's interest began with hookworm campaigns across the south of the United States and eventually the Caribbean and other parts of the world. But in Mexico, its interest was much more immediate, and that was staving off a perennial problem of yellow fever outbreaks. Now, yellow fever was endemic in Mexico, although addressed through various means, but for the United States and its busy ports, it was an epidemic problem that had a certain periodicity. And because folks had not been exposed to yellow fever previously, given it was an epidemic rather than ongoing and endemic issue, it had a very, very high case fatality rate, sometimes up to 50% due to this very lethal acute viral hemorrhagic disease transmitted, as it was known at the time, by the Aedes aegypti mosquito. And because this mosquito was able to survive shipborne, the problem was of interruption of trade. So anytime there was, as you see announced in this 1920 piece regarding yellow fever in Mexico, published in the New York Times, there would be a call to interrupt trade, stop whether it was coffee or oil or sugar or fruit, any other exports from Mexico and other ports across Latin America. And so it came at a huge cost to capital. For Mexico, yellow fever wasn't such a major problem. Before the revolution of 1910 to 1920, the famed Mexican public health leader, Eduardo Liceaga, had spent a great deal of time investing in sanitation and piped water so that the storage of water in receptacles outside of houses would not become breeding sites for this mosquito vector. And so rather than pick up on this effort at improving sanitation, the Rockefeller Foundation actually campaigned for several years to try to enter Mexico with a yellow fever campaign. But there was enormous distrust and need to negotiate. It took almost 4 years for Mexican officials to allow the Rockefeller Foundation to come in. And what they did when they came in was mount a massive inspection of hundreds of thousands of homes, application of mosquito larvae killing oil and larvicidal fish to millions of water receptacles and other stagnant water sites. And over the course of 3 or 4 years, actually was able to, if not eradicate Mexico, eradicate yellow fever, eliminate it from Veracruz and other crucial ports, and also gained the goodwill of the local Mexican population, not so much around yellow fever, but because this was really the first time public health officials were seen in their homes, in their local communities, and this generation of goodwill was extremely important, and so led to Mexico's invitation of a subsequent campaign against hookworm. Now, hookworm disease is a problem of sanitation and impoverishment, again, in context without sanitation. And it is a tiny worm that is excreted through the feces and enters the body through bare feet, makes its way through the capillary system, gets coughed out, and then digested and feeds on the intestines and leads to anemia. Right. So this was known as the germ of laziness. The lack of productivity in the United States South was ascribed to the hookworm problem. And here you see this really extraordinary photo of, staged of course, of a Rockefeller officer who has boots up to his knees. There's no way that his bare toes are going to walk on hookworm infested feces, but you see the children who are either barefoot or the mother in huaraches and so on. So there were also efforts to convince the population to build latrines, but this was extremely costly, and the idea of being in private for defecation was certainly important to the Rockefeller officer, not necessarily to the population at large, due to issues of inconvenience. Where the latrine was built might not be next to the fields where folks were working and so on. And so the other part of this campaign was the use of medication called chenopodium, which was toxic in large quantities. And one of the ways in which Rockefeller officers were so pleased with the campaign is they said someone could take the chenopodium in the morning, a member of the family might die, and the rest of the family would go and seek their medication later on that day. This happened rarely, but still the fact that they would highlight this is quite extraordinary. And there were also behavioral dimensions. This is a classic pamphlet from the Departamento de Salubridad Pública of the 1920s, which tells the story of this little boy who was weak, should have grown to be strong, but he was sick from hookworm. And unlike his older sister, he didn't get his chenopodium, didn't go for care early on. And so she grew up to be strong and healthy, an affront to have for this boy to have a taller, younger sister, an affront to, kind of macho values. And yet this is seen as a very important way of reaching out to the public. So after the hookworm campaign terminated, there was an effort to establish local health units. So here you can see some images from these units. What's most striking is that the Mexican Departamento was asking for investments in major problems: infant mortality, tuberculosis, onchocerciasis, malaria. But the Rockefeller Foundation refused because these would require enormous long-term investments in housing, occupational health, nutrition, sanitation, and so on, and at the time did not have ready technical interventions. Here you see a really interesting photo of the medicalization of midwives in Morelos. And here they're equipped with all of the latest medications, nitrate ampules, forceps, sterile tape, and so on, as well as the Mississippi Midwives Manual. So the idea here is that you could simply export, but at this the American approach, but at the same time stripping parteras of their traditional roles. So massage, the temazcal, herbal approaches, and so on, and requiring them to be reliant on physicians and to blame themselves if anything should go wrong. Another aspect of these campaigns, I mentioned that the yellow fever campaign was especially a problem for the US, given its impact on trade. That was largely funded by the Rockefeller Foundation. But the hookworm campaign And the health units you can see here were largely funded locally, whether by the municipality, the state, or the national department. Rockefeller Foundation only funding about a little over 10% or a little, of the budget. And you can see here across a number of years, the Rockefeller Foundation's contribution was 16%. Sorry, this is for 1932, across a number of units, just 16% of the total. So you have this, shall we say, imposition, inculcation of a particular public health model that is ultimately paid majoritarily by the Mexican government at multiple levels. So just to summarize quickly these principles of what I call international health cooperation based on philanthrocapitalist health in Mexico, you see 6 of them. Agenda setting from above, so the activities being donor driven, formulated, overseen by the agency, whether in country or through the awarding of grants. Very important, this agenda setting point. Remember, I was talking about Mexican demands for onchocerciasis and tuberculosis and so on. And support for all of those issues and problems. Budget incentives, as I've just mentioned, activities only partially funded by donor agencies with so-called recipient governments committing substantial, and I just mentioned financial resources, not mentioning human, physical, and other resources to any cooperation. A technobiological paradigm, so very reductionist approaches, biological, behavioral approaches, and technical tools that are seen as applicable to multiple settings. A priori parameters of success, didn't have much chance to talk about this, but campaigns and efforts were typically bounded geographically via short time spans by disease and intervention, and with clear exit strategies. So ensuring the demonstration of efficiency and almost corporate-like quarterly reports with the number of liters of insecticide sprayed and so on. Then, and we'll talk about this in just a moment, consensus through transnational professionals. So the training of public health fellows, often at Johns Hopkins, Harvard, London, for the case of nurses at my own University of Toronto, and involved in international networks, easing the local translation of these endeavors. And then ultimately this of course is not simply imposed from above, but operates in some kind of reality check, response, etc. So I want to turn to this now. We're looking at the resistance of capitalist approaches to public health in the Cárdenas years, which is an extraordinary period in Mexican history. Cárdenas was elected to the presidency in 1934 amid enormous political turbulence and labor activism. And the Rockefeller Foundation really feared a turn to socialism and repeatedly compared Mexico to the Soviet Union in terms of watchwords like socialization of land and industry, mass education, socialist health, and so on. Some years later, the foundation was satisfied that despite anti-capitalist and anti-church murals of Diego Rivera, Orozco, and other muralists, even though they were as common as the red posters in Moscow, the political cultures of the two countries differed markedly, with Mexican masses interested, quote unquote, not in ideology, but in material betterment, and not particularly concerned over the system through which they get it. Of course, as we'll see as we'll hear in a moment, there was a nationalization of the oil industry in 1938, and yet the Rockefeller Foundation said that they did not sense any hostility to the capitalist Yankee or any suspicion of his dollar diplomacy. Now, this is important to note that this took place also during the Franklin Roosevelt so-called good neighbor policy, when the United States was trying to ease back a bit its interventionism across Mexico, but really across Latin America, and try to be more of a quote unquote friend or neighbor. We can get back to that in the discussion, the extent to which it was or wasn't true. Here, I just want to point out that you have the HAYDEN system that was developed under the Cárdenas administration, which sought to set up medical units not according to the Rockefeller model, but rather according to traditional collective landholding, with contributions and what today we might call community-based approaches to medical care. Again, no time to discuss in any detail, but this was also coupled with, in the mid-1930s, mandatory social service for first physicians and nurses, so that there was a means to distribute health personnel across the country. And at the same time, and this is, I think, the most extraordinary of all, very, very clever at the Cárdenas administration at conveying its efforts to the United States. So here you see a booklet in English published by the Secretary of Health, Jose Ciurub, called Modern Tendencies of Public Health. I actually found it in the National Library of Medicine in Washington. And it's precisely at the time period, it's published precisely at the time period when Franklin Roosevelt was seeking to pass national health insurance in the United States and failed. So it really is, in many ways, a thumbs up and a showing how the strong Mexican man society is able to tackle that snake of disease in a way that the United States cannot. So I mentioned the Rockefeller Fellows very briefly, and here you see the fellowships that were awarded and the way in which the Rockefeller Foundation tracked fellows, so the position before the fellowship, where they studied, the latest known position. And this wonderful quote, if infiltration of the governmental health structure of Mexico with trained personnel continues, the outlook is with real optimism. So this was a shift under the Cárdenas administration from investments, particularly in health campaigns, disease campaigns, public health units, into the training of personnel. And I track the number of fellows, and you can see this real acceleration in the 1930s and this switch in approach. Now, the fellows didn't simply...
Yeah. We're approaching the 20 minutes.
I'm approaching 20 minutes?
Thank you.
Okay, so let me try and finish up quickly. So the fellows didn't simply fall into place, but Miguel Bustamante, a famed public health leader in Mexico, as well as at PAHO, said, we don't make blind imitation or copy, but transform and adapt to our local environment. So let me just finish up, if I can, with a little bit of art, science, politics, and philanthropy. Some of you may be familiar with this mural in the Palacio de Bellas Artes. It was actually originally commissioned by the Rockefeller family for its new Rockefeller Center, a complex of shops and offices, really a homage to capitalism on Fifth Avenue in New York City. And Diego Rivera painted this, not this, but a predecessor to this extraordinary depiction of potential directions for modern life. So you've got a robot-like worker controlling the turbine at the center, and you have the wonders of science on the capitalist side, with dying stars and the syphilis spirochete, and on the socialist side, the wonders of cell division and a new star, and so on. And then war versus women athletes. And of course, most disturbingly for the Rockefeller family, this figure of Lenin joining the hands of a Black and white worker. Now, the press got a hold of this story and said, this is, absolutely outrageous. Rivera is painting scenes of communism, and John D. Jr. Is footing the bill. and Rockefeller then suggested that Lenin's face be replaced with someone less problematic, maybe Abraham Lincoln, for example, less offensive. Rivera, of course, refused. Within a few weeks, he was called from his scaffold and forced to stop working. And he left and repainted in the Palacio de Bellas Artes, this painting, this time with an image of John D. Rockefeller among the capitalist smokers and gamblers. And lastly here, just thinking through a piece of art work, if you will, a public art in another venue. Here you have a plaque honoring John D. Rockefeller at the Departamento de Salubridad Pública and hailing the foundation's very powerful contributions to shaping health activities, and the US ambassador, Josephus Daniels, who had ordered the US 1914 invasion of Veracruz, stressed that no wall is so high, no barrier so strong that we can confine germs and bugs to any one country. Sounds a little familiar. So all are rejoicing at this form of cooperation. And yet, exactly 6 months later, on March 18th, 1938, Cárdenas nationalized the oil industry, taking over the operations of British, Dutch, US oil companies, including Rockefeller's Standard Oil and other companies, and raising a firestorm of controversy. Now, Time magazine went from portraying Cárdenas as a bumpkin to a man of vision. So I just want to leave you with this thought that although the Rockefeller Foundation was mistaken in thinking about art as neutral, or Rockefellers themselves, we could also see the problematization of public health being viewed as neutral on the part of revolutionary Mexico. I don't have time to go through some of my other slides, but I do urge you to think through some of these dilemmas and how crucial it is not to be naive about either philanthropy or mainstream public health. Thank you so much.
Brilliant, absolutely brilliant presentation. We enjoyed it very much. Next is Emily Vasquez. Emily is an ethnographer of science, medicine, and public health. Her research examined how social inequalities are entangled with and reinforced by the production of knowledge and development of new technologies across these expert fields. Emily holds a PhD in socio-medical sciences and sociology from Columbia University and is currently a bridge to the faculty postdoctoral fellow in the Department of Sociology at the University of Illinois at Chicago. Her work has been supported by the US National Science Foundation and the ACLS Mellon Foundation, and has been published in journals including Engaging Science, Technology and Society, American Anthropologist, and Medicine, Anthropology and Theory. Dr. Vasquez's presentation for today is titled Philanthropy and the Reengineering of Public Health in Mexico. The floor is yours, Emily.
Okay, thank you, Alexis. Can you hear me okay? Yeah, wonderful. This is perfect. I'm so excited about how this picks up just from where Dr. BIRN left off. My talk today is drawn from my doctoral research focused on health politics in Mexico in the domain of chronic disease prevention. During my research, the Carlos Slim Foundation came to the fore as a key actor in this arena. And my comments here will focus on the foundation's material and, even more importantly, the foundation's epistemic impact, which I think is a topic very much alive in Dr. BIRN's comments. So as many of you know, the Carlos Slim Foundation has come to figure as one of the most powerful philanthropic organizations in Mexico. Of course, far beyond the realm of philanthropy, the influence and economic power of Carlos Slim himself is difficult to elude, and in Mexico and throughout the Americas. As a British journalist observed several years back in The Guardian, It is virtually impossible for Mexicans to go about their lives without in some way contributing to his fortune. They are born in Slim's hospitals, drive on his tarmac, smoke his tobacco. They build their houses from his cement, eat in his restaurants, talk on his phones, and sleep in bed linen made in his factories. On the way to becoming the richest person in the world, a position Carlos Slim would hold between 2010 and 2013, in 2007, the engineer and telecommunications titan announced a significant expansion of his philanthropies. This included a significant expansion of the health sector of the Carlos Slim Foundation with an initial $500 million dedicated to addressing Latin America's most pressing public health concerns. That's US $500 million. In contrast to peer institutions like the Gates Foundation, rather than funding external proposals for public health initiatives, the expanded health sector of the Carlos Slim Foundation would assume the role of a think tank, analyzing health needs in the region and funding solutions of its own design. The goal, representatives of the foundation told me, was to partner directly with local and national government to eventually see these solutions integrated into public policy. Representatives of the Carlos Slim Foundation have also promoted the organization's initiatives and philosophy through a nationalist lens. By doing so, they have in many ways circumvented criticisms levied at peer institutions, such as the Gates Foundation, which are often painted as external elites imposing foreign visions for development. Cultivating the foundation's profile as a local and extremely capable health sector partner, its representatives have established a largely unchallenged, intimate relationship with the Mexican government over the last decade. Thus, unsurprisingly, in an interview conducted in 2019, then Secretary of Health, Dr. Jose Naro Robles, described his secretariat's relationship with the philanthropic institution to me as follows. We have an extraordinary alliance with the foundation. There is a symbiosis, a sum of capabilities, of possibilities. More broadly, across publics in Mexico, the foundation is often perceived as more technically and ethically competent than the state itself. Indeed, emphasizing the scarcity of state resources for chronic disease prevention and medical services, one position reminded me, at least Slim is doing something. But exactly what is the something that the Carlos Slim Foundation is doing? I agree that extraordinary benefits can come of the philanthropic initiatives of the Carlos Slim Foundation and its peer institutions like the Gates Foundation. But my aim here is to make clear that as health challenges are increasingly placed under the stewardship of private philanthropies like the Carlos Slim Foundation, we're faced with an important reckoning regarding their influence, the influence of these elites, the privileging of their values, interests, and tools over how we collectively recognize health and how we conceive of potential avenues for its attainment. As development scholar Adam Federstraff has observed of the elite philanthropists now influencing public health globally, and this is true in the case of Carlos Slim, their approaches are consistently guided by logics of the individual, the market, and of societal progress through technological innovation. Sounds familiar to our last presentation. Certainly, the digital and communications technologies that have fueled Carlos Slim's corporate empire are also at the center of the public health initiatives that the foundation has promoted. Moreover, as I'll describe in more detail in a moment, the solutions that the foundation has promoted also draw on applications of cutting-edge, experimental, and high-cost science, particularly in the domain of genomics and metabolomics. Dr. Roberto Tapia Conyer, former Vice Minister or Subsecretario of Prevention and Health Promotion at the national level, head of the foundation's health sector, and now the foundation's Director General, has also described the foundation's approach as social investment. The foundation aims to foster public health by supporting innovation in the private sector, funding critical research for new technological developments with an eye toward their commercialization. Early on, in a talk at the University of California, Irvine, Dr. Tapia Conyer explained that with this approach, the foundation would share risk with private investors. Through such partnerships, Tapia Conyer continued, the objective of this social business model was to make technological innovations for public health widely available in national contexts like Mexico, where the cost of their wider implementation in the public sector might otherwise be unaffordable. Importantly, these private investors include Carlos Slim himself, whose corporation also has invested in the commercial side of the foundation's endeavors. Carlos Slim thus ranks among those contemporary philanthropists increasingly referred to as philanthrocapitalists. As sociologist Lindsay McGooey has observed, this contemporary breed of philanthropists is notably proud, triumphant even about the private economic gains to be made alongside their charitable donations. And among them, it is no longer necessary to disguise or minimize self-interest. Let me turn now to the specific programs and technologies the Carlos Slim Foundation has promoted for chronic disease prevention. As I take us through this list of initiatives, please keep in mind that my concern is not just their implementation, the integration of these initiatives and technologies into public health practice, but more so their epistemic power, what collectively they signify that public health can and should be. I'll begin with the MIDO program. In 2010, the Carlos Slim Foundation launched the Integrated Measurement for Early Detection Program, known by its Spanish acronym MIDO. The MIDO program entailed the installation in centros de salud of an all-in-one diagnostic station for chronic disease screening and counseling, as well as an electronic information system that enables long-term patient data monitoring. The MIDO technology was intended to target apparently healthy patients, including family members accompanying sick patients to health clinics, rapidly screening them for chronic diseases, for pre-diseases such as prediabetes and pre-hypertension, and for traditional risk factors, including elevated body mass index, abnormal blood sugar, high cholesterol, family history of disease. In this way, according to the foundation representatives, the MIDO system was designed to resist the dichotomization of screened individuals into healthy or sick, and instead promote an understanding of pre-disease stages so that healthcare providers and patients could treat risk rather than illness only. Treatments to reduce or control individuals' risk might involve recommendations for changes to their lifestyle, including diet and exercise. In the case of prediabetes, this advice might also be accompanied by a prescription for metformin, a first-line diabetes drug used to treat the initial stages of diabetes. The foundation's representatives told me that they viewed the diagnosis of pre-diseases such as prediabetes as a way to jumpstart a shift across Mexican society toward taking chronic disease prevention seriously. It's shock therapy, one representative told me in an interview. You need to give the patient a nudge so that he wakes up. In other words, the representative explained, the intention is to be able to tell individuals who are at risk, quote, don't think you're healthy, you're on the threshold of being sick, end quote. Indeed, in its approach to chronic disease prevention, the foundation emphasizes the notion of individual empowerment. The MIDO program relies on the conviction that if a patient wakes up to his or her risk, he or she will be motivated and able to adopt healthier behaviors or adhere to a preventive drug regime. It also assumes health system capacity to carry out this screening and the long-term treatment of pre-disease with availability of drugs, availability of diagnostic testing for preventive monitoring, and the accessibility of nutritional guidance and opportunities for exercise. Now, the foundation did not stop at the detection and surveillance of traditional risk factors and pre-disease. Turning its gaze to the level of the molecular, between 2010 and 2013, the foundation donated $139 million to research to advance understanding the genetic drivers of diabetes, focusing on Mexican and Latin American DNA. Known as the SIGMA Initiative, this genomic research was carried out at the illustrious Broad Institute at Harvard and MIT in collaboration with key Mexican institutions in order to accelerate the project's pace of discovery. We didn't want to invest in basic research to create basic knowledge, Dr. Tapia-Caño explained. We wanted to be able to convert that knowledge immediately into policy action. Indeed, urgency around translating the genetics of diabetes into technologies that would have a clinical impact was at the heart of the SIGMA venture. And the foundation wanted progress on an entrepreneurial rather than an academic timescale. As one SIGMA scientist explained, Slim's gift had come with a timeline for bench to bedside translation, i.e. the fast production of a marketable technology. The scientist told me, he's an entrepreneur. Slim said, okay, I'm going to put in this amount of money, but after 3 years, I'm going to get something out of it with potential commercial value. This goal of a fast return on Slim's philanthropic investments would also require infrastructure on the commercial side. Therefore, just as Sigma was reporting its first findings, the foundation founded a biotechnology startup firm, Patia Biopharma, drawing primarily on funding from the for-profit arm of Carlos Slim's conglomerate. As Dr. Tapia Conyer explained to me, this arrangement was a kind of experiment. It's an exercise, an initiative, he said, something very innovative, to create a firm where investment, private investment, literally stockholders, are linked with social investment, literally a foundation. What you get is a business with a commercial, but also a social vision at the same time, where its earnings are just sufficient, just above cost for its own sustainability. Ultimately, Patia and the Carlos Slim Foundation entered into a partnership guided by the foundation's self-described social business model approach, in which the two would be deeply intertwined, with Patia itself leveraging Carlos Slim's name and reputation in its effort to market the diagnostic technologies it would offer. As a first step, the company became Mexico's exclusive distributor of neurogenetics BRCA analysis test, which detects BRCA1 and BRCA2 gene mutations linked to hereditary breast cancer and ovarian cancer risk. Patia's second move was to enter the field of metabolomics, the study of small molecule substances formed during metabolism or necessary for metabolism to take place. Originally developed by a US biotech firm, Metabolon Inc., the diagnostic blood test QuANTOS-IR measures the level of certain metabolites in the blood that together constitute a novel biomarker for insulin resistance, a condition that indicates that an individual's cells are not responding normally to insulin. So not that they have diabetes, but that something is going wrong. In 2014, the test was exclusively licensed to the Carlos Slim Foundation, its collaborators, Patia Biopharma, and a Mexican laboratory for its commercialization in Mexico. When insulin resistance occurs, glucose cannot enter cells easily and instead begins to accumulate in the bloodstream. But rather than detecting the buildup of glucose in the blood, the QuANTOS-IR technology uses mass spectrometry to measure levels of insulin and 3 other non-glycemic or non-glucose related metabolites. These substances signal changes that occur years before changes in hemoglobin A1C and fasting plasma glucose are visible. So QuANTOS-IR can detect changes in insulin resistance that begin more than 10 years, according to its maker, prior to the glycemic changes that a standard A1C test detects. In the private clinics in Mexico City, where I conducted some of my observations, the test is used not only for the early diagnosis of insulin resistance, but also to assess a patient's progress over time in lowering their level of diabetes risk. By design, QuANTOS-IR allows for further improvement even after insulin sensitivity has been achieved, a move deeper into the green zone, away from the red zone. In this respect, my own score of 10 suggested that although I'm in good shape, I could still do better. A state of no risk remains elusive. Now, following the introduction of QuANTOS-IR, by 2014, the Foundation's investments in genomic medicine through the Sigma initiative had led to the discovery of 2 genetic variants linked to heightened risk for type 2 diabetes among Mexicans and Latin Americans. For many of the scientists involved, the discovery of this association represented a preliminary advance in knowledge in this area and a starting point for a program of research to determine the variant's functions. Nonetheless, on the basis of these findings and with the backing of the Carlos Slim Foundation, Patia Biopharma proceeded to develop and market a test that would allow Mexicans to determine their genetic predisposition to type 2 diabetes. This test, called Diabetes Prevent, entails a cheek swab to collect a DNA sample. The sample is then tested for the presence of 16 different genetic variants, including the 2 discovered by Sigma scientists. The test applies an algorithm based on the presence or absence of these variants to produce a type 2 diabetes genetic risk score. Patients receive their score either from their doctor or if they've taken the test at home via smartphone. The app also doubles as a health management portal through which users are encouraged to input and track data about their health, diet, and exercise to help them manage their risk moving forward. When I interviewed PATIA representatives in 2018 and 2019, they were lobbying the Secretariat of Education to pilot diabetes prevent in schools. One representative explained that while parents may know, based on family history alone, that their children are at risk for developing diabetes, the diabetes prevent test would provide a score, a measurement, something material and tangible that he believed would motivate lifestyle change. While representatives of the Carlos Slim Foundation continued to work to win uptake for its technologies among policymakers in Mexico and recognition on the world stage at scientific conferences, framing these new risk diagnostics as the foundation's intellectual contributions. In Mexico, the foundation launched one of its most substantial deployments of both Quantos IR and Diabetes Prevent, drawing on its deep-rooted connections with the Mexican Secretariat of Health, particularly in the state of Puebla. This entailed a campaign to test over 2,000 patients in primary health centers in which the nation's most vulnerable receive care. Data from the pilot study would grow the company's database substantially, helping to refine its proprietary algorithms. It would also contribute to the evidence base on which to demonstrate the utility of these diagnostic tests to the Secretariat of Health and other health institutions to justify a scaling up of their deployment across and beyond Mexico. Launched in 2016 and fully funded by the foundation, the campaign made use of the foundation's pre-existing MIDO program, amplified in Puebla under the name MIDO Plus or MIDO Plus, and with Quantos IR and the genetic diabetes prevent now incorporated into the screening model. The foundation's idea was to combine the results of the two new genetic diagnostic tests via an algorithm to produce an overall metabolic risk profile. Then physicians and other health providers would be armed with a map for how to customize clinic-based prevention to each profile. So the foundation had prepared guidelines for physicians on how to deal with 21 different risk profiles by the time I finished my fieldwork. Together, these technologies are proof of concept for the foundation's vision for diabetes prevention and for the future of public health more broadly. As the foundation's Director of Global Solutions, Miguel Betancourt, explained to public health students in 2019 in Puebla, what I'm going to tell you goes totally against what our public health professors have taught us since our first engagement with this discipline, that public health is about population dynamics. Here we're going to the other extreme, to the most intimate, most individual aspect of each human being. Genomics and a few of the other fields we'll see at work today are enabling us to individualize risk, create profiles, and better characterize our population for targeted intervention. This, he explained, is personalized public health. He went on to add, this is public health. This is the National Center for Prevention and Control of Disease, handing out metformin across the country. But we know who we need to give it to and in what moment in accordance with their risk type. Ultimately, MIDO, Quantos, Diabetes Prevent, and MIDO Plus work together to re-articulate what public health can and should be according to the values and ethos of Carlos Slim and those representing his foundation. This new paradigm of personalized prevention in public health entails population stratification through routine diagnostic testing with clinical resources directed toward lifestyle interventions and potentially pharmaceutical treatment among those predicted to be most at risk. This new paradigm would, of course, also support the expansion of prevention markets, specifically for diagnostic technologies capable of detecting risk and for individualized therapeutic products to deal with risk where it is found, as well as markets for related laboratory infrastructure.
Emily, sorry, we're at the 20-minute.
Okay, I'm gonna need 2 more minutes. Let me finish up. Thank you. So what's come of MIDO Plus and the foundation's efforts to promote personalized public health? While MIDO stations are located, let me switch to this, in 27 states across the nation, and risk screening is available in metro stations in Mexico City, the broad introduction of Quantos IR and Diabetes Prevent have not been widely taken up in the public health system. By 2020, the largest uptake of these technologies had come through the foundation's alliances with corporations who made them available to employees as part of wellness programs to motivate health lifestyles, including within Carlos Slim's own corporations. But this reality does not lessen the significance of these technologies and the vision for public health that the foundation has promoted. With the exception of MIDO, while these advanced technologies are not found widely in clinics across the country, for more than a decade, the foundation's representatives have been powerfully promoting them and the notion of personalized public health on the national and world stage. At conference after conference of the Mexican Academy of Medicine, at diabetes conferences, at UN-sponsored conferences on global health, they've disseminated this vision, linking it to the unquestioned technical authority, intellectual prowess, and knack for corporate efficiency and vision of Carlos Slim himself. The epistemic influence that I'm describing here is intimately entangled with this charismatic power of Mexico's wealthiest entrepreneur. Ultimately, the authority of both Carlos Slim's persona and the political connections of the foundation's leadership have effectively directed the Mexican medical and scientific community's attention away from structural conditions and toward genetic drivers and behavioral, if not pharmaceutical, solutions. And what are the implications of the particular vision for public health the Slim Foundation has promoted? We've talked about the quantitative differentiation of risk and the triaging of public health action to smaller groups across the population. At first glance, this approach appears to be more efficient, but much more is at stake. These technologies and the risk stratification they make possible encourage targeted action aimed at those most at risk and carried out through the medical system, rather than through structural interventions that could resolve population-level risk through comprehensive social actions such as food policy reform. Reducing risk among those singled out as on the edge of disease is very different from building a society that cultivates health. The social contract between the state and its citizens centers on facilitating the latter's access to the consumption of an array of products, as opposed to protecting them from the actual sources of harm rampant across Mexico's obesogenic environment. As public social welfare programming in Mexico increasingly converges with Slim's vision for health and development, it's critical to challenge the reconceptualization of public health as a commercial industry and to consider instead public health action to protect citizens' bodies from commercial markets and the ill effects of increasing wealth inequality. This is the difference between technologically innovative, but also highly conservative neoliberal approaches to public health versus a more radical approach. Public health could be otherwise. I'll stop there.
Microphone, Alex.
Oh, sorry. Thank you very much, Emily. I was stumbled by the quote of Miguel Betancourt. It's just a fantastic quote that encapsulates a lot of what we're talking about here. Next, we have César Torres Cruz. César is a full-time associate researcher at the Center for Gender Research and Studies at the CIEG at UNAM. Dr. Torres is a graduate in social communications from the Universidad Autónoma Metropolitana, Xochimilco unit. He holds a master's in social sciences and humanities with a line of specialization in sociology and gender studies. And he holds a PhD in political and social sciences from UNAM. He did a postdoctoral stay in the Science and Technology Studies group at the Faculty of Sciences at UNAM from 2018 to 2020. His research lines are gender, health, and sexualities. Dr. Torres is part of the National System of Researchers DERSNI of CONACYT. Dr. Torres' presentation for today's panel is titled US Big Pharma and the Stratified Biomedicalization of HIV and HPV Sexual Risk in Mexico. Thank you very much, César. The floor is yours.
Gracias. Hola, buenas tardes a todas y todos. Hi, everybody. I'm going to try to speak in English, so I'm going to read my presentation. This presentation aims to analyze how sexual risk to prevent both HIV through PrEP and the implementation of HPV preventive vaccine in Mexico has been biomedicalized within stratified outcomes. From a sociological feminist perspective, I will talk about how these two contemporary biotechnological alternatives have following US pharma criteria in Mexico. Theoretically, I use the concept of biomedicalization introduced by Adolph Clark and her colleagues to analyze the role of biomedicine in redefining social life. This concept emphasizes, and I quote, the increasingly complex, multi-site, multidirectional processes of medicalization that today are being both extended and reconstituted through the emergent social forms and practices of a highly and increasingly technoscientific biomedicine. These changes in biomedicine are apparent in interactive processes such as the political and economic reconstitutions of biomedicine, increasing focus on risk surveillance through technoscientific practice, and transformations in the distribution and consumption of biomedical knowledge, as well as the emergence of new individual and collective identities. Additionally, these authors acknowledged that biomedicalization is not experienced uniformly across societies or across diverse health disease conditions. To emphasize these differences, the qualifying concept of stratified biomedicalization was introduced to refer, and I quote again, to the selectivity and strategic nature of biomedicalization, its unequal and sometimes unintended effects across populations, and how this might exacerbate rather than ameliorate social inequalities along many different dimensions. Thus, biomedicine is stratifying its availability, imposed, made accessible, and or promoted differentially to different populations and groups, with both health-related and broader social consequences. I have been carrying ethnographic research within medical practitioners, epidemiologists, and government politicians involved in both PrEP and HPV vaccine implementation in Mexico. In what follows, I will share some insights to remark how sexual risk is stratified among populations. Stratified access to PrEP, the unequal construction of subjects at sexual risk in Mexico. Antiretroviral drugs have been implemented worldwide since 2007, when the US CDC recommended its use in occupational exposure events. From 2015, PrEP has become a critical relevant biotechnology to prevent HIV acquisition. In Mexico, the UNITAID sponsored a Latin American trial called IMPREP, which started in 2018 and remains ongoing with Mexico, Brazil, and Peru as participant countries. I had the opportunity to carry on an ethnographical approach at Clínica Condesa in Mexico City, a biomedical entity of the IMPREP trial. I searched for the ways epidemiological criteria were used by physicians to define who is at risk to acquire HIV, since PrEP here in Mexico is available only for cis gay men and trans women. A mechanism producing stratification involves the ways biomedical discourses and practices define certain identities and subjectivities as high-risk sexual subjects. This means, in practice, that beneficiaries of public health services, like those offered at Clínica Condesa, partially both their distinctiveness and rights in contrast to other perceived and competing groups of beneficiaries. For instance, one HIV activist said in one interview that, and I quote, "For him, it is important to focus on key population vulnerable to HIV, such as gay men and trans women, who have the highest prevalence in Mexico." However, when I asked him what he thought about heterosexual cis women, he replied that there are a lot of poor women affected by HIV, and I quote again, "since they cannot demand that their husband to use a condom due to machismo. Still, their vulnerability is different from the one experienced by gay, cis men and trans women. And maybe they need other sorts of promotion, prevention, and detection strategies. Grassroots gay HIV activism thus provides a channel not open to cis women. These groups support the exclusive implementation of HIV prevention regimes among cis gay men and trans women. Moreover, this differential access to PrEP not only reflects the non-symmetrical access to public health services, but also reinforces those differences and shows the distance between gay and feminist activisms in Mexico City. When I confronted medical practitioners about the decision to restrict accessibility, they answered that despite the fact that there were currently no PrEP program outside this trial active in Mexico, in Clínica Condesa, they could prescribe PrEP under particular circumstances to cis women and cis men with no cost. Nevertheless, there are no existing local policies to assess risk among these populations, including such silent factors as experience of intimate partner violence, which remains pervasive in Mexico. Perhaps more importantly, in defining who is at risk, Clínica Condesa has followed epidemiological criteria created in the US health institutions, which impacts PrEP access differentially. Although my informants claim that Mexico is not merely following a global trend, a regime that has been designed and then mobilized from abroad, a medical practitioner explained to me that, and I quote, "Actually, we have a delay," he said, because the WHO launched the recommendations 7 or 8 years ago, but we took so long in thinking how to implement it in the country. We were thinking on a strategy to do it. When a trial, the Unity trial, came up, we decided to take part in it. Indeed, Clínica Condesa follows the US CDC guidelines prevention on sexual risk, the one you are seeing on the screen, created in 2015, to decide to whom and when to administer PrEP. A physician said about it, "The orders are not coming from the US. We follow their guidelines because their guidelines to assess risk are very efficient. We also follow the Mexican official norm and other European guidelines. But the one the CDC elaborated has been implemented worldwide for many years. To assess sexual risk, I used a print sheet of paper, this one. This is the CDC risk calculator. Here it is," he told me. And it says that in 10,000 exposures to HIV with someone infected without his viral load suppressed, the highest probability is when someone is anal receptive without a condom, 138 in 10,000. Then the next highest probability is for the one who plays the role as an insert, 11 in 10,000. Then a woman who is penetrated by a man, 8 in 10,000. The chance for a man to penetrate a woman is 4 out of 10,000 times. Regarding oral sex, as you can see here, this table doesn't even have a number. The risk is pretty low. I give people the scientific evidence and then they have to decide what kinds of sexual practices they are going to have. Now let's move to HPV. The biomedicalization of girls through HPV preventive vaccine. HPV is an important virus since, according to the WHO, 80% of the global population are living or will live with it. In the Americas, Asia, and Africa, cis women acquire one of the types of this virus, either the 13 or the 16, that can lead to cervical cancer, which in this context can become lethal for these women. Merck pharmaceutical company implemented in 2006 the US Gardasil vaccine. In Mexico, following US trend, this US trend, the vaccination was approved in 2009. However, in this country, its use is only available for adolescent cis girls from 11 years old. A very important element in the public policies of attention to HPV and cervical cancer of the WHO and the Mexican Health Secretariat is related to the way in which they position a biological element as a trigger for a high degree of vulnerability to which women are exposed. The causal relationship between HPV and cervical cancer. According to the WHO, and I quote, almost all cases of cervical cancer are attributable to HPV infections. The WHO Plan of Action of the Control of this Cancer states in the same vein, and I quote again, cervical cancer is caused by the persistent infection by high-risk types of HPV. However, feminist perspectives have criticized the univocal nature of this supposed causality. For instance, Aletia Guerrero, after searching epidemiological texts that analyze the correlation between HPV and cervical cancer, realizes that there is a bias in this causal relationship because HPV is not an homogeneous viral group, and having any of its variants is not necessarily a sufficient condition to develop cancer. Furthermore, within the causal relationship between HPV and cervical cancer, although the physical vulnerability, the possibility of acquiring HPV and its eventual development in this type of cancer, until for many women is recognized, public policies ignore other diseases from this virus that could lead to other types of cancers, just as relevant as cervical cancer. For instance, anal, buccal, vaginal, and pharyngeal, which also represent high rates in Latin America. Within this process of stratified biomedicalization, we witness a cultural feminization of HPV's experiences. As many feminists have argued, that vaccinating only the girls, it contributes to representing cis women as carriers and transmitters of a virus of sexual nature. As Laura Mamo and Stephen Epstein argue, since the rise of HIV epidemic, the pharmaceutical industry and its politics continue to shape the environments with regard to the production of risks and the severity or not of the disease. Currently, the global sexual politics are focused in providing stratified biomedicalized alternatives to intervene in sexual risk immersed in several types of cancer. For Mamo and Epstein, a complex desexualization dynamic is in constant transformation. Therefore, and I quote, despite the differences in material characteristics of this virus and their associated cancers, we find a constant trend towards evidence of sexual transmission to generate both familiar and renewed ideas about the disease and stigmatized identities. The way these viruses are conceived and treated is always determined by specific historical cultural links and conceptualize health, disease, and risk according to the needs of modern biomedical institutions and the pharmaceutical industry. Thus, the analysis of the internal components and external determinants of these viruses can help to make visible the broader social, political, and cultural arrangements that structure the new sexual politics of cancer. In the case of HIV prevention, we witness a social processes of desexualization of the discourse around this virus. Since Gardasil approval in 2006 by the US FDA, there has been experienced in so many countries like the US and some parts of Latin America, such as Mexico and Colombia, controversies along several lines, including whether this vaccine might provoke promiscuity on the parts of teen girls. In order to diminish this social trend, the pharmaceutical company Merck pursued a strategy, and I quote, of deliberate desexualization of the discourse around its vaccine in order to smooth the path to acceptance, regulatory approval, and uptake of the vaccine, strategically promoting Gardasil not as a vaccine against HPV, but rather as a vaccine against cancer in women, end of the quote. When I asked several government bureaucrats, as well as epidemiologists in charge of the HPV vaccine public policy in Mexico, why this vaccine is only available for girls, they told me, and I quote, because the risk is more present among them, among women, they meant. In Mexico, we don't have enough budget to vaccinate men. It's a matter of working with a few amounts of money for a lot of population's needs. Men are excluded from any specific practice of medical intervention, except from some states where children in this age are vaccinated through epidemiological research trials. The absence, says Laura Mamo, the absence of males in vaccination is not surprising, given the historical, medical, and cultural pathologization of women's bodies, considering them as subjects ready for medical interventions. In attending Abel Clark's invitation to carry out empirical research to document if biomedicalization theory is applicable transnationally, this presentation showed the complexities immersed in the ways stratified biomedicalization occurs in HIV and HPV prevention in Mexico City, a context where, with a characteristically historically produced fragile grip of technoscientific interventions. With these cases, we can see the complexities of the adoption of US biomedicine in Latin American contexts. HIV and HPV have seriously affected the lives of many people, especially the most vulnerable, poor, indigenous, trans, and cis women, men with homoerotic practices, and young people. Technoscientific strategies will not be enough if public health policies do not take into account the sociocultural complexities of Latin American countries. Something very relevant with the cases presented here has to do with the differences and gender relations immersed in the stratified biomedicalization of sexual risks. On one hand, with PrEP, we can see how the biomedicalization of men's sexuality with homoerotic practices continues. On the other hand, and although it seems contradictory, despite the stigma that biomedicalization of homoeroticism entails, we can also appreciate how these men take advantage of this gender condition, that is, of being men, to fight for more technoscientific interventions. With the implementation of the HPV preventive vaccines, we appreciate how women continue to be subordinated in the experience and exercise of their sexuality. In most cases, they acquire the virus from the male partners under supposed monogamy agreements. In addition, there is a higher prevalence of HPV and cervical cancer in poor women, what in Latin American countries translates into a high mortality rates, which could be preventable. Unlike the case of PrEP, women affected by HPV do not have a direct relationship with detection and prevention biotechnologies, an aspect that also reveals the gender inequalities that persist in the region. With HPV, we see the feminization of viruses, and in both cases, HPV and HIV prevention, we observe how biomedicalization of sexual risk offers useful biomedical alternatives for people, but also challenges for its universal implementation, which end up intensifying stratified access to health services. Thank you very much.
Thank you, César. I loved how you painted a very complex picture. It's not just the straightforward, against biomedicalization. I love that about your presentation. Thank you very much. Now, finally, we have the last presentation for today. And it's from Professor CORI HAYDEN, who is professor and former chair of the Department of Anthropology at the University of Berkeley. She's the author of a book that I loved when I read it the first time, When Nature Goes Public, from Princeton University Press. And she's, I believe, currently writing another book, which is going to be published by Duke, which is called The Spectacular Generic. Professor Hayden is co-convener of the USC system-funded Clouds and Crowds Working Group. Her presentation is titled Beyond Big Pharma, Medicines and the Politics of Universal Coverage. Thank you very much, CORI. The floor is yours.
Thank you so much, Alexis. And sorry, I was fiddling with my screen while you were talking. It's such a pleasure and privilege to be part of this panel. I think the papers are flowing so beautifully from one to the next. And thank you to CÉSAR for setting me up to talk about pharma, otherwise, big and otherwise. So I'm going to be talking about a sort of strange version of all of the questions that you all are tackling. And I think in the end, they will, the pieces will come together. So bear with me. But let me just say to start that I think one of the biggest transformations in Mexico's public health system over the last 20 years or so has been, of course, the expansion of state programs meant to cover the 50 million people or so who in the early 2000s did not have access to a public health and social security program or system premised on formal employment. IMSS and ISSSTE, obviously the biggest pillars of that traditional system. So we saw from 2003 to 2019, the invention and rapid expansion of the Seguro Popular as a kind of, well, a popular security program, a way to cover all of those who did not have access to formal employment and therefore to healthcare in a formalized health system. Now we know the Seguro Popular did not survive the Cuarta T, so we now have INSABI, so I'm very curious to know how that's going for those of you there. But for the moment, what I want to talk about, in today's presentation, what I want to talk about is an ancillary development that I think is completely central to the expansion of a healthcare state in the form that it took over these last 2 decades. And so I want to talk about, I guess, something that is thoroughly entangled in these institutional additions, but that is not the same. It is not lo mismo. Right? I want to talk about Dr. Simi in the context and farmacias similares, because I want to talk about the fact that at the same time, I'm sorry, my screen sharing thing has been weird. Let's try that. That at the same time that the Seguro Popular, first of all, was in its sort of being created from whole cloth and then expanding with such sort of tremendous rapidity and scope, we saw also the invention from whole cloth and the expansion with tremendous rapidity of a private, low-cost consumer market for generic drugs. And very much part of the expansion of this market for cheap medicines was the model of a market for cheap private health consultations, general care, primary care, right? Those consultorios that charge 20 pesos a shot, etc. And those consultorios that come attached to many generics pharmacies across the country, not just farmacias similares by any means. That is a model that has spread rapidly. Now, in many ways, of course, this is a phenomenon that feels homegrown, and Dr. Simi, Victor Gonzalez Torres are sort of, you know, as Mexican as they want to be. They also have expanded their own enterprise rapidly across Latin America. But at the same time, I'm very interested in the resonance of this expansion of a private market in pharmacies and clinics, alongside the expansion of a healthcare state itself constantly in flux. And I'm interested in those two expansions together as they resonate with some broader directions in global health and international public health. Broadly, I would say that these trends that I want to talk about, or these resonances, I should say, raise questions together about what counts as public provision, what counts as private provision, and how do those definitions themselves keep shape shifting, right? So the three trends or buzzwords or directions in global public health or global health that I want to mention here, and I won't have time to go into them in any depth, but that I see as thoroughly entangled in the rise of Dr. Simi and the rise of these just incredible range of pharmacy chains in Mexico selling generics and cheap medical care, are first the politics of universal coverage, or what gets called cobertura universal, a kind of international project of a priority spearheaded by the WHO and the World Bank. Second, what get called in kind of economic development languages, a kind of evangelism around that, around development, the base of the pyramid approaches to health and development. And third, very significantly, I think for our concerns today, is the rehabilitation of self-medication or automedicación, not as a vice to be avoided, right? Or a prohibition, or being a bad pharmaceutical actor. We've all been encouraged to say no to self-medication, but actually, if you look at what's happening in global health right now, self-medication is becoming actually the pillar of a reimagined approach to bringing health to the poor. Okay, so what I hope to do is just sketch, these are all three complicated stories. I just hope to sketch how CIMI or pharmacies more generally, but CIMI is such a delightfully vivid example. And these institutional shifts kind of work together and run together right through all three of these considerations. Okay. So let me start with just the questions of medicines and access. My task within this panel initially was to talk about pharma. And, when we think about the relation between big pharma and public health, one of the first things that I think of certainly is that nexus, that overdetermined nexus of patents, leading brand prices, therefore access, and therefore affordability or lack thereof. And certainly, the private market for generic medicines was invented in the last 2 years of the 20th century by Ernesto Zedillo in the waning years of the PRI's 20th century run, in part, and it's a longer and complicated story, but in part as the state's response to the outsized hold that the transnational drug industry had on the consumer private market in Mexico. So if you think back to the days before Dr. Simi, Dr. Ahorro, Farmacia San Pedro, etc., right? If you had access to IMSS or ISSSTE and you go to that pharmacy and they don't have your drug in stock, where would you go instead? You'd go to Sanborn's, you'd go to the Farmacia in the corner. What do they sell? They're not selling generic medicines. They're selling name brand drugs for the most part, and they're quite expensive. Now, if you don't have access to IMSS or ISSSTE in the first place, and you're buying listed pharmaceuticals, those also are your only options, right? Now, that situation was becoming increasingly untenable in the late 1990s, certainly following the peso devaluation of 94, following the further strengthening of intellectual property regimes through the TLC. That was a time when the transnational industry had, for no good reason except political power, close to 90% of the private consumer market in medicines, right? So this translated in many ways, together with the fact that fully half the country did not count with formal employment, those two facts together led to a very alarming kind of situation where health costs are concerned in Mexico. Mexico had sort of the highest out-of-pocket expenditure on health among all OECD countries, and medicines accounted for 88% of those out-of-pocket costs on health. And those costs are borne disproportionately by the poor, right? You can imagine a crisis in access can just simply be that. You cannot afford to buy medicines, and IMSS and continue to have problems with desabasto. This is a headline from just now. This is not a new problem. It's also not an easily decipherable problem, and I don't take it at face value. There's a lot of politics behind continued arguments that IMSS don't actually have medicines, and that's a whole other story. But if we take the problem of desabasto in whatever way it manifests, the problem of price in the private sector, you have a real issue around access to medicines, to affordable medicines of any kind, analgesics. I'm not even talking specialized medicines for PrEP or for insulin, for example, but like anything. So together, these problems of desabasto and price led to the formation of a private market private consumer market for generic medicines. Zedillo kind of set it in motion with two things: a prescription decree that said that physicians must now prescribe by generic name, not just brand name. So loratadina instead of Claritin, for example. Now, a prescription decree all by itself, as Raul Molina Salazar, the economist at UAM, he says, look, a prescription decree already breaks monopolies, right? You prescribe loratadina instead of Claritin, you've broken the monopoly already, right? At the same time, Zedillo issued in new regulations on what would count as a generic medicine. And here we could go into an hour of talk about regulatory categories, thresholds of equivalence. It's very relevant, but I'm going to skip it for now in the interest of time. Okay, now, what happened? What happened? You had, let me just start. I have just a lot of noisy slides here. Let's just go to this particularly noisy slide. There's just this kind of proliferation of many things at once. Sorry, wrong screen. Right? You had a very rapid proliferation of generic pharmacies of many types, big chains, little ones that copy Dr. Simi and call themselves similares, these like one-off kioscos, and then ones in between, the pharma económicas of the world that are sort of formalized informal pharmacies, right? You have a proliferation of types of generic medicines. Again, I won't talk about that, but it's important to the story. And very importantly, you have the proliferation of a model in which pharmacies have consultorios alongside, bringing both cheap medicine and cheap primary care into the circuits of popular and middle-class consumption. Now, this is a new landscape of access enabled by notably deregulatory zoning politics. Like anybody can open a pharmacy pretty much anywhere. I could open one, well, maybe not me. Y'all could open one right now. And lots of people do. They're like, hey, let's try this. And the seeming ubiquity of these pharmacies has created new ways for people to traverse the landscape of access. I don't have to go looking for the Seguro Social clinic. I don't have to waste a day. These are the laments we hear all the time. I don't have to waste a day off work waiting for the doctor to see me. It's like, no, the Similares is right on my bus route on the way home. I don't even have to go looking for one. A lot of people, so many people have told me this. I don't even have to go looking for one. They're just right there, right? Now, I think this is important. And back to the question of what's the relationship between these pharmacies and institutions of public health. By 2012, CIMI's consultorios alone, so not all the other ones, but farmacias similares in particular, funded and managed by Victor González Torres' private philanthropic foundation, Fundación BEST, were providing between 4 million and occasionally up to 6 million consultas a month, second only to IMSS, which provides around 8 million a month, right? Now, that's an enormously interesting fact. Let me ask though, what does it have to do with the panel? How does this, what do we make of this story? So let me take in turn those three kinds of shifts or considerations I wanted to bring to your attention. The first is the question of universal coverage. Right. So I started off by not talking about Dr. Simi, but talking about Seguro Popular, for example, right? Now, the generics market and Dr. Simi were not the only forces changing this terrain of access in the first 2 decades of this century. The Seguro Popular started under Vicente Fox with Julio Frank as his Secretary of State. Was a massive intervention in providing healthcare for the poor and otherwise underserved in Mexico. You all know it better than I do, I'm sure. I would just say that it explicitly was meant to expand coverage and services free at the point of access to those who did not count with formal employment and so didn't have access to IMSS or ISSSTE. For a time, until López Obrador killed it, it was considered a major success story, almost a poster in the annals of global health. It was, in fact, part of a larger suite of international experiments, in many cases, certainly studied, if not funded or helped organized, with the participation of the World Bank, the World Health Organization. There were experiments, literally called experiments, in India, in France, Thailand, Brazil, Vietnam, all under the rubric of universal coverage, and all recognizing that social welfare programs based on formal employment no longer serve anywhere in the world, right? Now, they were mechanisms for extending health coverage, but they are also understood to be sort of innovations in administration, in financing. They're seen as technocratic experiments. They are meant to be decentralized, as the Seguro Popular was in Mexico. Sometimes they're funded by philanthropic organizations. Sometimes they are, undertaken in the name of public-private, collaboration, partnership. The Lancet has run a whole series of articles on universal coverage and its successes or failures or challenges, and it's all very technocratic in a way. So here are 11, lessons from 11 country studies. It is like a social science and public health policy experiment, just like it's out there to be had. And within that parameter, Mexico was seen as a major success story, right? You might remember that in 2012, Julio Frank could announce, like, success, we have done it. 52 million people enrolled, right? How does that happen, right? It was a dramatic, remarkable, in fact, expansion of access to state services and many medicines. It was an experiment with decentralized funding mechanisms, often running through states rather than the federal government. This is part of López Obrador's critique. Often leveraged in the idiom of state-family co-responsibility, if you remember that. These are key neoliberal buzzwords. And all of it, though, without, you might recall, a correspondingly large centralized expansion of infrastructure. So access without infrastructure. Now, there's a whole cottage industry, of course, of evaluations of the program and now postmortems and nostalgia for it. But let me just cut to one crucial question. How do you expand healthcare to 52 million people in a decade without expanding infrastructure in any real hardscaped, meaningful way. Well, my work on generics and Dr. Simi, I'll just give you the punchline without going through the steps. It is very clear that there's no way the Seguro Popular could have expanded at the rate that it did without the commerce in generic medicines available to absorb the excess. And by excess, I mean people who want medicines, but whom, you know, the Seguro Popular nor IMSS could necessarily provide, right? And in fact,
sorry, where are the 20 minutes?
Okay, great. Let me just give you 2 more slides real quick. Okay, the next move was Farmacias Similares serving as a kind of poster child for another kind of approach to global health, which is leveraged in the name of the base of the pyramid. That is ensuring that the way to bring health and development to the poor is not to freeze them out of markets, but rather to consider them as excellent market actors, people who should be served by markets. And one of the big pillars for experiments, again, in this idiom, is health. And one of the major formations for bringing health to the people as a market is cheap, low-cost pharmacies, okay? So I'll just say that, there's a lot more to say, but let me go to point 3 as a way to wrap up. Rehabilitation of self-medication. Within that move, right? The base of the pyramid approaches to health are like empowering people to open pharmacies, to sell medicines cheaply, to bring people in the door through cheap consumption. In order to do all of that, you are also recognizing that, as BOP approaches say, the itineraries of the global poor, when they get sick, often take them to pharmacies as their first point of contact when they're ill, when they need care, right? That pharmacies are often the place where you go when you don't have money to go see an actual doctor, you don't have access to public health. And that fact has then produced a kind of rewriting, a reorientation of the language of automedicación, right? That we are not supposed to self-medicate. We are not supposed to self-prescribe. We are not supposed to go buy antibiotics because we have a cold, right? We're not supposed to do that. But now the World Bank and the World Health Organization are literally redefining self-medication as self-care. And in fact, making a kind of ploy for promoting responsible self-medication as a way to make yourself well, but also as a way to reduce the burden of healthcare on governments, right? Now, that's kind of a new orthodoxy in global health. And it is one that we see in Mexico. The sort of over-the-counter medicines industry is very excited about this move. And so there was a conference in 2015 by makers of over-the-counter medicines who are really holding on to this language of self-care and responsible self-medication, right, as a way to reconfigure healthcare. All right, I'm definitely way over my time here. So I will just leave you with that. No, I'm gonna leave you with that slide here. So on the one hand, we have this reconfiguration of what constitutes public care, what constitutes self-care, what constitutes private care, how these systems are actually working in concert with each other, not just public versus private, but public expansion because there's an expanded private market. You know, that relationship needs to be thought about, I think. And then the last thing I'll just say is that the generics market in Mexico is so tasty and large and tempting that a lot of the transnational firms who have generics divisions are entering this market right now, right? coming back here to say, aha, this is where we need to be. So they are using the generics market to come back into a market that was invented precisely to contest their dominance in the first place. But they are now starting to find their way back in, and prices are going up, actually. And I'll leave you with that very optimistic last note. Sorry to go over. Thank you, Alexis, for your patience.
Thank you very much, Corey. We have some time for questions. I think we have a couple on the chat. First question is for Emily. I'm going to read it to you, Emily. Could you speak about the parallels between the Carlos Slim Foundation epistemic assumptions about the importance of technological interventions and other philanthropic initiatives, I would think, like the Bill and Melinda Gates Foundation?
Yes, and I'm sure that Anne-Emmanuelle can add, because the sort of emphasis on technological solutions certainly is not new to the current cluster of philanthropy that is just as a reflection of where money has come from over the last couple of decades in our world. Philanthropy that's tied to Silicon Valley, to tech markets. I think Dr. Byrne's presentation about the Rockefeller Foundation shows that continuity very well. And I think the other, and this has been written about by others with regard to the Gates Foundation and the idea of a magic bullet. Zuckerberg, Mark Zuckerberg in the US, I mean, the list goes on and on. But I think the story is richer in that, and Dr. Byrne started to tell this story. It's the idea of fixing, of solutions that can be achieved on a particular time scale with a particular kind of expertise and in measurable ways. And it's that move toward quantification that we saw very clearly in the Rockefeller case that continues on to the Gates Foundation and to Slim's work, where it's more than just that I think technology can solve our problems. It's also a way of solving problems, the work of solving problems, how we would go about proving that this is making a difference, which is really, you know, it's about a core value of how we believe we should justify social action. We should justify social action via quantification versus thinking about a rights framework, for example. And so I think that underlying story is really important in terms of unifying the trends that we're seeing in philanthropy of elites.
Anne-Emmanuelle, would you like to add something?
To underscore the idea of profiteering as a form of contributing. And I didn't get a chance to go into this, but actually the Rockefeller Foundation pioneered this in part through public-private partnerships in the 1990s and also through impact investing and legitimized it. They're no longer the largest actor in global health, but had this trajectory to legitimize that approach. And it's so, so beautifully crystallized by Dr. VASQUEZ, by Emily in that presentation. So, and you have to remember also that a lot of the players actually overlap and move back and forth between the foundations. That's clearly the case between the Slim Foundation and the Gates Foundation, but also others. There's a certain circulation, as well as with Big Pharma and so on. So there's a circulation of folks who take on this approach and are very skilled at implementing it. And perhaps the most nefarious dimensions are the extent to which they're moving into national governments as well as to international organizations like WHO. So yes, very, very much intertwined, although I think each foundation with its own particular patina. So I think that's interesting as well.
Fantastic. I don't want to miss the opportunity. I would like to ask you, this is a sort of personal question. What would be your take on these issues regarding, the production of the COVID vaccine? I mean, exactly, they are profiteering in a sense, very clearly, while not reaching millions of people in the global south. So I would just like a brief comment before I move on to the next question. To Emily.
Everyone.
Yeah, everyone.
Let me defer to others. And
I'm not sure if I want to go first. Let me think about it for a second. Corey, maybe you want to start with.
Did I say patent regimes? I mean, it's very, as I have a student, I should give props to Zara Hayat, who's just written a piece in Medical Anthropology Quarterly precisely about this issue. And, it's not just about being stingy with patents, that there are, with many of these medicines, they're very complicated to make. And so there's a lot of things besides the patent that can be kept secret, even as you disclose a patent, which just makes the diffusion of technology to other drug makers that much harder, and really requires a spirit of cooperation rather than a spirit of stingy, just a little bit, just enough disclosure. So that's certainly one aspect. I mean, I think you see the age-old debates right now about the fact that many of these vaccines were developed, in fact, with enormous amounts of public investment, and yet are being called private property that must be protected at all costs. And it's unconscionable.
Anyone else wants to jump in?
I mean, I'll jump in. I mean, I would just
please.
say from, yes, there are the complicated production processes, manufacturing processes, but a growing number of countries in the majority world have that capacity. So, and many have been quite nimble. I mean, Senegal and others, over the past year and a half. So yes, it's stinginess on all of these dimensions. But I also would point to the inability of extant global governance mechanisms. The TRIPS agreement, Doha Declaration, responding to really massive uprising by HIV/AIDS activists and right to health activists and so on, called for patents to be waived or parallel importing to happen in the context of a public health emergency. How a pandemic can not be defined as a public health emergency is just beyond the most absurd mocking of the global governance system. And the outrage is beyond that. And then also the game playing. So finally, the Biden administration said, "Oh yes, we agree," but Germany, it has to be consensus. So Germany won't agree to the patent waiver, or Britain or the EU. So some real, very cynical game playing, I would say.
Yep, thank you. Completely agree. We have a question from Cápsulas Teóricas to CÉSAR. In your ethnographic research, did you find some agency around sexual biomedicalization?
Thank you for the question. I don't know if I have to answer in English because it's asking someone in Spanish, I guess. Yeah, I'm going to speak in English. Yeah, of course. That was if I found agency, right, in people in biomedicalization. Yes, I did. I found it more presently in the case of PrEP, because I also researched some homoerotic circuits where some friends were sharing Truvada, and there were accessing Truvada for free in a recreational way, and they were also self-medicating. I mean, they were taking Truvada, and that was a way to be on PrEP by their own. That doesn't happen in terms of HPV preventive vaccine. So I would like to say that gender is also determinant in these cases. So I think the agency is crossed by gender and social class. And in terms of PrEP, I only could reach middle class postgraduate students who identified as gay, as men, and that doesn't happen with women. In the case of HIV, neither the case of HPV. So I think gender and social class are such determinants to get access to biomedicalization. And I could say that agency is also determined by social class and gender.
Thank you very much, Cesar. I think we reached the end of our time. Thank you very much, everyone. This was a superb panel. I really thoroughly enjoyed it. I hope we can post it really soon on our YouTube channel. So I will send you the link pretty soon. Thank you very much again. And we're at CISAN truly honored by you spending some time with us. Thank you very much.
It was a pleasure to meet you all, actually. And Emily.
Pleasure to meet you all.
Muchas gracias por haber estado con nosotros y gracias, Alexis, por organizar este panel de primerísima. Muchas gracias.
A usted.
Buenas tardes.
Gracias.
A ustedes. Mil gracias. Chao.
Chao.
Hasta luego. Bye.